Actually, we started in our last 6 session. We tried to cover obstetric anesthesia. We started from the basic pharmacological, physiological, and anatomical consideration, and just trying to correlate them into the clinical practice. How we modify our clinical practice when we are dealing with an obstetric patient, and the obstetric patient we will be finding in the form of any pregnant patient for an obstetric surgery, or a pregnant patient for any non-obstetric surgery or any complications. So that's how we approached, and some of the points were remaining. So I will just try to wrap up those things. Azhar, can you just take a little bit of lead? You appeared in the exam before. Can I ask that some of the points on which you found any questions from the obstetric anesthesia, because they will be giving you a scenario, and they will be asking you a question, for example, to next step in the management of pre-eclampsia. Am I right? So you have to choose between among the medication or among the next step. Am I right?
Sir, you're right. Actually, usually the scenario comes like that. Okay, if there is a patient and who has a fit and blood pressure with high blood pressure, and what would be the choice of drug that you will administer? So usually usually magnesium sulfate or labetalol. So these are the sort of paid questions of the CPSP that usually come. They usually ask from the main topic they ask is preeclampsia, eclampsia, and they ask even uh, uh, local anesthetics toxicity and like that, sir.
Okay. So if, for example, if you have a question in which they have given a scenario to choose between magnesium and any antihypertensive, so which usually what factor will define this thing? Like in which scenario would you like to go for magnesium, or usually in which scenario you will go for this one, antihypertensive? Yes, Azhar. Like usually, if you have a patient with imminent eclamptic fit, and you have a high blood pressure as well, like they will be giving you a scenario in which there will be things related to end organ damage because of preeclampsia. Okay, so in that patient there will be more chances of developing fit. So maybe the first thing to do will be to start magnesium sulfate, okay, rather than antihypertensive. It depends, but usually it can be like that. Okay. Just a second. Some of you might have seen in this book, and this is Anesthesia Comprehensive Review. I will, because actually today I had to wrap up few of the things. The people, the residents who have been preparing, have you seen this and this book, this MCQ book? And this is Comprehensive Anesthesia Comprehensive Review. Okay. So for example, uterine contractility tone is affected by anesthetic agents and techniques in all of the following ways except. Like just try to recall what are the factors which affect the uterine contractility.
Tone. Uterine tone.
Okay, what's that?
To hold the baby in proper.
No. What factors will affect the uterine tone? Like if we just say in what stages of anesthesia there will be some effect in uterine tone, or what medications will have effect.
Magnesium sulfate will affect the uterine tone, and blood flow, uterine blood flow. Hormones,
Even our inhalational agents affect uterine tone, sir.
Yes, that's what I'm asking you. That, for example, if we go by step by step, inhalational agents will decrease the tone. Okay. What about IV agents?
So,
reduce the tone. They will also reduce the tone.
No, there is no effect. If you know the who anyone can comment. What about muscle relaxant?
sir, muscle relaxant had no effect on the uterine tone, sir.
Okay. What else?
And
what about this epidural?
Epidural, sir, if in the pain, motor fibers may definitely that will affect. Otherwise, if we increase the concentration, then if motor fiber, then there will be effect. Otherwise, the pain concentration will not affect, sir.
Okay, so other medications which we use, nitrous oxide has minimal effect. So actually, this uterine contractility tone is affected by anesthetic agents and techniques in all of the following ways except. Okay, so you have to find the incorrect answer. Okay. So which should be the answer? Like if we go, uterine tone is not affected by muscle relaxant. This is a correct statement. Volatile inhalational agents have a dose-dependent relaxant effect. This is also a correct statement. Okay. Opioids do not have any effect on uterine contraction. This is also a correct statement. Nitrous oxide has minimal effect on uterine contraction. This is also a correct statement. So this is a wrong statement. Uterine tone is reduced by epidural local anesthetic sympathetic blockade, which is why labor is longer with epidural analgesia. Okay. So labor epidural is not associated with any increase in chances of cesarean section or causing uterine relaxation. It does not has effect. Okay. If anyone can add any other factor which has effect on uterine tone, and I will just give you the idea how to factors. This is how you should be doing one single MCQ. Okay, because then you will not forget. Okay. They will be telling you all the factors. Okay, but usually okay, this is also a question that less than 1 Mach it will have less effect. This is theoretical concept. Okay, and what about factors if we add to uterine tone, uterine blood flow? What are the factors which will affect the uterine blood flow?
Sir, definitely hypotension will affect the uterine blood flow, and position of the patient, supine position, there will be a decrease blood flow to the uterus, and
okay, what about hypoxia?
Hypoxia will decrease the uterine blood flow, sir?
Yes. Any sympathetic stress use of vasopressors, okay, like any factor which is causing stress, okay.
Sir.
Spinal anesthesia.
Spinal anesthesia with hypotension, okay. Common clinical events that affect uterine blood flow in term parturient during labor and delivery include all of the following except, okay. So actually these questions are not ideal. This is, but people don't understand that this is for practice, okay. In the real time, if you ask someone, is it a good question? So it's not a good question. Except questions are not very good questions, not considered as a good standard MCQ, okay. Okay, uterine blood flow is decreased in most parturient when supine due to arterioval compression. So I think this is correct. Am I right? Uterine blood flow can be increased in about 15% of parturient when supine due to uterine arteries taking off above the level of compression of aorta. What do you think? Sorry?
It's wrong.
This seems to be wrong. Okay, we will see if anything else is more wrong. Okay. Uterine blood flow decreases when maternal systolic blood pressure drops below 80. This is correct. Okay. Effective epidural analgesia can increase uterine blood flow in the parturents with severe preeclampsia by up to 80%. Can increase uterine blood flow in the parturent with severe preeclampsia by up to 80%. So this seems to be correct. Okay. Maternal hypocapnia from hyperventilation causes uterine artery vasoconstriction, resulting in decreased blood flow. Okay, so I think this should be the correct answer because it's the most wrong. If but you will interpret, if so, whosoever is looking at this discussion for us, that's how you should be doing the practice. Okay, like in this statement, you have to see what is the normal PaCO2 in maternal, in a pregnant patient. Yes. Azhar?
20, 40.
Sorry? No. Dr. Homera, you have to think before answering. What about 20 to 40? 20 to 40 is not the correct answer. It is slightly lower than normal. What is the normal PaCO2?
20, sir.
20? No. Please, you are wrong. Azhar, tell me. What is the normal range of PaCO2?
Sir, around 40, sir?
Like 35 to 40, no?
Sir.
So it will be slightly on the lower side in pregnant patient, okay? And usually hypocapnia, you can just recall the effects of hypocapnia. When you are reading such statements, you can read effect. And what is the reason for this increase in uterine blood flow in parturient? By epidural? What is the reason for it? By reducing the stress response. Okay. When there is stress, that's what I was telling you. Then whenever there is more stress, there is decreased uterine blood flow. Okay.
Okay.
And a 26-year-old G1PO parturient at term delivers a 3.5 kg boy vaginally. After 30 minutes of obstetrician grows concerned that the placenta has not delivered. Okay, the patient is transferred to an operating room position for manual extraction of the placenta. After the placenta is removed, the obstetrician notices brisk uterine bleeding. All of the following medication would be contraindicated in the specific condition identified except. Actually, the scenario will be that the things which you should be recalling in this scenario. What are the concerns when you are anesthetizing a patient with retained placenta? Yes, Azhar. Anyone? Actually, the patient will be bleeding. Okay. Patient may be in shock. Patient will be considered full stomach. What else? Patient will be in stress. Okay. So these are the things in addition to what you are facing. So now, how will you decide between general anesthesia versus any other? What will be the choices of anesthesia?
We will go, definitely will go for GA, sir.
Can you speak a little louder? I cannot hear you.
Sir, we will go for GA, sir.
Why you want definite GA? Can't you give spinal?
Sir, spinal will further decrease the blood pressure, sir.
Okay. Okay.
And,
so can you say that you will be doing the risk versus benefit in this scenario? You will be see the extent of the patient. Not all retained placenta patients will be hypovolemic. Okay. So you will be assess the patient, and if the patient is in shock, then you will not go, but otherwise you can give. Okay.
sir.
So you have to consider according to the scenario you faced. Okay, what else? So there will be concerns related to full stomach patient. Okay.
Sir.
And then like usually what we do. Okay. So now in this now you will be thinking about the factors which you think should be considered. Usually in after delivery you are giving uterotonics. Am I right?
Sir.
But in this scenario, what would you like to use? How will you consider? Like if they want to do that, because similar scenario is uterine inversion. Okay, you can have a scenario almost similar to this patient. That patient delivered, but now the uterus is inverted. What will you do? You understand my question? In that scenario, you have to give the uterine relaxants. What relaxants you can give at that time? You can give some gas, you can give some magnesium, you can give some nitrate. Like in that scenario, the tone is too much increased. That's why you have to, initially they will be doing it surgically by massage and everything, but you have to relax the uterus in that scenario when the uterus is inverted. And here you have to give some uterine tonics. So in this MCQ, actually, they are asking you in which scenario you will not be using some medication. Okay. So, what should be the answer? Yes, Azhar.
Sir,
What is methyl intramuscular? Would you like to use in preeclampsia? So this is correct.
Sir.
Okay. What about carbopos, PGF2 alpha? You don't use in asthma.
Sir.
Okay. Then
Sir. Oxytocin.
oxytocin, you will not use in hypovolemia. Okay.
Sir.
What about misoprostol in maternal fever?
I think that can be used, sir.
Azhar, you are very, your voice is not coming clear.
Sir, I think the misoprostol we can use, sir.
Yes.
Better
So I think this is the correct answer.
Sir.
What do you think? We will confirm it. 3. Okay. So that is the correct answer. Okay. Okay. But you know, the message which I want to give you, that when you are practicing, you should not be doing like that. You should be looking at the dose. So many points you will learn even in one MCQ. Am I right?
Sure.
Okay. So that, okay, a 20-year-old G1PO parturient at 32 weeks gestation with no medical problems was in a high-speed motor vehicle accident She was wearing a seat belt and has only abrasion on her face and chest. On arrival to the emergency department, she is awake and alert. Maternal vital signs are 100/60, blood pressure, heart rate 120, respiratory rate 20, fetal heart rate evaluation shows a persistent fetal bradycardia in the 70 beat per minute. A wide bore cannula is placed and the patient is taken to the operation. Most appropriate anesthetic choice would be. So in this MCQ, what other things you need to, things you need to revise for yourself? I will chalk out. You should be revising what are the concerns in a patient with trauma with pregnancy. This is one thing, number one. Number two, you can revise how will you categorize the shock? Okay, you can again revise what are the causes of fetal bradycardia. Okay, and how can you manage a patient with fetal bradycardia on anesthesia floor? Like for example, in this scenario, what you should be your response? Though we are attempting this MCQ, but in this you have to use your brainstorming with these questions. You can revise at this time. Even ATLS, if you can just have a revision in your mind. What are the concerns in ATLS? What is the primary survey? What is the secondary survey which we do? Okay. And another, she was wearing a seat belt. There is when we were discussing trauma, we discussed about whiplash. Okay. So actually, that is how you should be practicing. Okay. And if you do like that, I guarantee you, maybe it will take more time, but at the end of the day, you will have a lot of knowledge. If why people fail, say, I have read this book, I have read this book, I have read this book. Actually, the reason for their failure is that they are not doing any brainstorming. They are just reading the text, finding the answer, who is their darling. Like their message is only find the answer, who is their darling, and that's go move on. And that's the reason for their failure. Okay, so now come to the question, which will be like in this scenario, the patient is in shock, patient is full stomach, patient is pregnant. There are 2 lives. You have to achieve the effect quickly. So these things should be in your mind when you are doing it, and patient is definitely in the shock. Blood pressure is on the lower side, heart rate is more, and patient is tachypneic as well. Okay, so what should we do? The most etomidate 0.2 milligram per kg with succinyl 1.5 milligram per kg. Propofol 2 to 3 milligram per kg with succinyl. Spinal injection of bupivacaine 12 milligram and fentanyl. Spinal injection of bupivacaine 12 milligram without fentanyl. Inhalational mask induction with preserved spontaneous ventilation until anesthetized to avoid emergent tracheal intubation in a trauma patient. Okay. So I think spinal will be out. So these 2 things are out. Okay. Inhalational mask induction. Sorry.
Even propofol will be out.
Yes, propofol we will come. So these 2 things will be because of why you are refusing to give spinal.
Patient is already in the shock.
Already in shock. This is one thing. This is one reason, and there is another reason. That is fetal bradycardia. You don't have time. Even if the patient is relatively stable, you can say that this is stage 1 shock, for example. I just guess it like because she's awake and alert. Okay. They are not telling any sign of about urine output or about the skin turgor or peripheries, etc., etc., etc. Okay. So if we consider that this is not a severe shock, so you can consider spinal if there is no fetal bradycardia. Okay. But in fetal bradycardia, you don't have time to do the spinal. Okay.
Sure.
In this way, I will give you another thought. What is rapid sequence spinal? There is a terminology, rapid sequence spinal. What is rapid sequence spinal? Have you heard about it?
So it's only I understand from the word is just we have to give a spinal very quickly.
Quickly means you have to be in turbo engine. Is it like that?
Sir.
No, actually you are giving the spinal because a number of things which you can avoid is, for example, you have to give the spinal in lateral position. You are doing co-loading rather than preloading. Okay. And you can have a combination in the way that it is increasing the effect is coming quickly. Like you can add some which Which thing you can add to achieve the effect quickly?
Vasoconstrictor.
Vasoconstrictor, Azhar, I should have a stick for you for this answer. I'm not expecting this answer from you. Vasoconstrictor is to increase the time duration, not enhancing the effect, quickening the effect. For that thing, you can have to add bicarb. Okay.
Bicarb.
Have you used lidocaine in spinal? People used to have lidocaine in spinal. Okay, so these are the things which you can just recall. So answer should be etomidate, of course. Okay, because you are not giving propofol. Even they have written a very higher dose. It's not 2 to 3 milligram per kg. It's slightly higher dose. Okay. Any question by it? This is, I'm requesting you, whosoever is watching this, even in the recording, I will request you to study like this. This is the way to target MCQs. But the people who are not bothered, they are having a pool of questions. They are trying to ratify the MCQ answers, and sometimes it's very effective, because if you have the pool of questions which are coming repeatedly and you are ratifying them, and that's it. Anyways, next question is 32-year-old G3P2 parturiente with no medical comorbidities, with a 29-week twin gestation, presents with regular contractions. She is stable and apparently no distress. On examination, she is noted to have a closed cervix. The obstetrician decides to administer terbutaline to stop contractions. Side effects of therapeutic regimen might include all of the following except. So now we have a what is terbutaline? It is beta 2 agonist. So you should be considering the effect of beta 2 agonists. Am I right? Okay, so you have to recall the what are the effects of terbutaline, Azhar?
Sorry, sir, I can't recall, sir.
Just think, beta 2 agonist, tachycardia, tremors. Am I right?
Sir.
Where we use beta 2 agonists to treat hyperkalemia. Am I right?
Sir.
Why we just it is pushing the potassium inside the cell. Okay.
Sir.
So what else? We are using it for bronchospasm, so it has bronchodilation effect. Okay. Whenever there is tachycardia and so there is chances of patient having some arrhythmias, tremors. Okay. What else? Whenever there will be tachycardia and increase, like so patient can have like pulmonary edema as well. Okay. So in this question, this seems to be the answer, because it is causing hypokalemia, not hyperkalemia. Okay.
Sir, you are right.
Because SVT can occur, hyperglycemia. What is the mechanism of maternal hyperglycemia actually? Can anyone explain? Hyperglycemia because of terbutaline. When you have a dog running behind you, you need more energy or less energy?
More.
So that's a sympathetic response. So I have not read about it, but I'm just guessing. So hyperglycemia, because it is a sympathetic stimulator. It's a beta agonist. So it should be increasing the blood sugar. Okay. So, and if it is passing through the placenta, it can also cause fetal tachycardia. So that's how you target. What are the other this one uterine relaxant you can use? We have just discussed a few minutes ago. What are the other? How will you compare other uterine relaxants with it? Yes, Azhar. Magnesium, nitrates, inhalational agents. Okay.
Sir.
So you can compare them with other options. Okay. Okay. An 18-year-old G1PO participant with a history of systemic lupus was diagnosed with mild preeclampsia. Okay. At 27 weeks gestation, she remained stable on weekly evaluation. 32 weeks gestation, she experienced the start of contraction in the middle of the night. After evaluation, the obstetrician decides to initiate tocolysis with a 4-gram bolus of magnesium, followed by an infusion of 2 grams per hour. The following morning, the patient is lethargic and has an oxygen saturation of 55%. In addition to oxygen fail, discontinuing the magnesium, appropriate initial therapy would be. What has happened to it? This is because of the toxicity, the respiratory effect of the magnesium. It has muscle relaxant effect. It has a smooth muscle relaxant effect as well. So actually, this is the reason for this scenario. The patient is going in respiratory failure. So what should be the forget about the options. What you should be doing? Your option will be airway, breathing, circulation. Yes. You can get calcium. What else? Airway, breathing, circulation. Try to be methodical. Would you be giving, if the patient they have not mentioned here blood pressure, but maybe this patient needs some fluids. Okay. If there is hypotension, you are treating the hypotension as well. You would be looking at the urine output. You would be sending the blood levels. You can do some ABGs. Okay. So these are the things which you are doing in this scenario. And then, okay. So what would be the appropriate thing? What would be the initial therapy what you would be doing?
Sir, what would be the benefit of ABGs, sir?
ABGs, you can have some electrolyte imbalance, which is potentiating this problem.
Okay.
Okay. And another thing is that, for example, if the oxygen saturation is 85%, would you like to see the patient is having any other ABG acid-base disorder? Patient can have hypoxia because 85 saturation is not a very accurate one. At this saturation, you are not sure how much is the PO2. So you have to look at the PO2. Maybe this patient needs intubation. Am I right?
Sir.
So ABGs will be mandatory, blood levels will be mandatory, urine output, ECG, and you will be looking at the patient overall. Okay. So now, ordering an echo to rule out peripartum cardiomyopathy. Is it the first thing to do? Most probably no. Okay. Furosemide. Do this patient needs furosemide?
No, sir.
Okay. Evaluation of evidence of myocardial ischemia, including AKG and serum protoporphyrin levels.
No, sir.
Okay. This may be needed, but it is not the initial therapy. Okay. This may be needed. This may be needed. Okay. So sublingual nitroglycerin tablets until an infusion of nitroglycerin can be initiated. No, this is not the requirement. Okay. So most probably answer should be calcium gluconate. Let's see what is the answer. Okay. So it's calcium. How will you compare calcium chloride versus calcium gluconate? Yes. How will you compare calcium chloride with calcium gluconate? Yes, Azhar. Anyone else? A calcium chloride has more ionized calcium. Okay. So it has 3 times more ionized calcium than calcium chloride, than calcium gluconate. Okay.
Okay.
So you need to give it in less dose as compared to calcium gluconate. It is more effective, but people say that it has to be given through the central line or something like that. Actually, in patients where you want to correct it correctly, it is better to give calcium chloride rather than calcium gluconate. Okay. Risk factors for postpartum hemorrhage include all of the following except. So like just imagine the patient factor, anesthetic factor, and surgical factor for PPH. We have discussed in detail the uterine atony, rupture, retained placenta. These may be the obstetric causes: placenta previa, accreta, percreta, vasa previa, things like that. And some patient factor like sepsis, some bleeding disorder. Okay. What else? Okay, and anesthetic factors like inhalational agents. What else?
Opioid.
Opioids, how it will affect?
So reduce the respiratory depression and then
No. It has no relation with postpartum hemorrhage. We are talking about PPH. Opioids, how it is a risk factor directly? It can be indirectly if you are using it in too much dose and not like that. Okay. So relative dilution of coagulation clotting factor due to plasma volume expansion during gestation. Is it the factor for PPH?
no, sir.
So I think this should be, we will see previous PPH, yes. Protracted prolonged labor, yes. Retained placenta, yes. Multiple previous uterine surgeries, yes. So this should be the answer. Okay. Actually, it's the other way around. It is a cause for pulmonary embolism and DVT. Okay. Okay. I will finish our discussion at this point because I have to go somewhere. I just wanted to have, because I was not able to do it, yes. But whosoever is listening, I will suggest you to target MCQs like that, okay, and be methodical and okay. Any questions?
Sir, for me, just a
We cannot hear you. We cannot hear you. I cannot hear you.
Is it better now, sir?
Yes.
For me, take home message is that we have to, if there is a one MCQ and targeting one aspect of the topic, so we have to all consider and study all the aspects of the topic, isn't it?
Yes. Okay, that's why people say that we have finished the book, but still they don't have the knowledge. The reason is that they are just concentrating on the darling. Their darling is the answer. They are not thinking anything else. Okay. Okay, everyone. Before we finish, Dr. Razia, ma'am, I would like you to comment something, because actually today I just couldn't send the link in time, and I just wanted to do something. So I just try to have some discussion rather than no discussion, and we will start some new unit, inshallah, in few days.
You asked about the use of xylocaine.
Yes.
Well, in emergency cesarean sections, xylocaine 5% heavy was the drug of choice about 2 decades or maybe 2.5 decades back, and I have used it a lot. But because of xylocaine toxicity, it was internationally abandoned. In fact, I was getting this drug into Pakistan from India for a very long time. And it has a very quick effect. Like if you give spinal in a lateral position and the lady turns a little late, you might not have an effect on the upper side.
Yes.
So this is one very big advantage of xylocaine in obstetrics.
Yes.
If in an emergency, if you have to give a spinal, but when we are using xylocaine in epidural, one can combine it with bupivacaine to produce an effect earlier. That's what I do in obstetric epidurals being converted into cesareans.
Yes. Yes.
But in spinal, I think 2% will not be a good choice, because 5% was the xylocaine which was being used in spinal anesthesia.
Yeah, and actually the reason will be also the presence of preservative.
No, but the xylocaine the xylocaine we use for IV, I think that can be given intrathecal also. That would not make
yes, you're right. Actually,
difference.
there are two sort of xylocaine available. One is preservative free, which they claim to use in IV, and in some they have only written for subcutaneous, some things like that. It's in Saudi Arabia, it's available like that. But
no, here in Pakistan we only have one, and that's, I think, preservative free, because that's being used even in epidural, that's being used IV everywhere.
Yes.
So,
yes.
And the preservative is not written on the ampules.
Yes.
So we take it for granted that there's no preservative.
Yeah, actually, by mistake, all over the world, I think all the medications have been injected in the intrathecal space in any part of world. Why? Because many people have injected saxamethonium, neostigmine. So there are so many drugs by mistake they have been injected in intrathecal space. But usually the rule which we follow is that the drug should be either it should be they are marketing as a preservative free or safe to use in the intrathecal, or because this Duramorph is sometime morphine which is available is not recommended for to be used in intrathecal, but people still use it. So that's the reality. We have sort of logistics. Anyways, ma'am, I'm really thankful to you to join us, and I will be very happy if I get some help from the residents and from the faculty back in my our country, so that I'm able to continue this thing in a better way, and there is no gap, because our residents, they are very fond of ratifying, cramming the MCQs, and when I invite them, they said, "Oh, sir, you are discussing Viva." So maybe today, if I have done for the first time, because my aim is to send the message and clear the concept. When they have clear concept, either they are asked in MCQs or Viva or SAQs or whatever scenario, they will be able to pick up the answer. But if they don't have the concept clear in their minds, they struggle, and they do struggle. Even if the people, because I have discussed this thing loud and clear in multiple forums, that I don't know why in our College of Physician Surgeons, they totally abandon the SAQs from their exam. It is actually it's a highly questionable act, because SAQ's pattern will give a chance for the person to be evaluated in a better way. Whole MCQ's pattern is good when you have a very developed pool and you are constantly updating it, and there is some evaluation back at the source. But actually, we don't have in practice evaluation very effective in our country. So I don't think so that it's a very good step to remove MCQs, to remove SAQs. And even in FRCA and Irish exam, which we are following a lot, they still have SAQs. and they have prematurely removed.
Actually, preparing keys for SAQs and evaluation is very difficult compared to the one best type of questions.
Yes.
That's the reason. And nowadays, all our evaluation system is so computerized that these short essay questions, you know, you have to make a lot of effort to make a key, like at least 3 or 4 sentences, which are the most important in that short essay answer.
Yes.
You have to make the key, and then to feed it into the computer and then to get the result. It's a bit tedious and difficult, which our examiners usually are not capable of doing.
There is a little bit in between solution. Is a new thing which is being used is CRQs, constructive response questions. Okay, this is in this they have to tabulate or point very like pinpoint. So it's a new thing. Even now, Irish fellowship exam, even they have in this COVID era, they have converted even their oral part into CRQs. Okay, so that's a very good idea. And actually, the thing is that you are, I agree with your point, ma'am. But the thing is that we have to be realistic and we have to look into the overall mentality and culture of our residents. And they suffer actually. They pass the written part, but they suffer in oral part, and practically they lack a lot. That's a problem. And we have to develop our MCQs pool in a way, because you know what is happening, that they are recalling it. There are tools available. They are doing it. Out of 200 questions, 100 questions are coming from that pool. So actually, there should be some way to actually, if you ask me, there should be action on the people who are doing it openly, because there should be some restriction for it, because it's being misused. They are not like reading properly, and then at the end of the day they suffer. Anyways, ma'am, thanks a lot. And
actually, the language also is a very important issue here. Yes. Because the feedback which I've got from students is that the construction of the MCQs is using wrong tenses, and then what happens, the student gets confused in answering.
Yes.
So
actually, that's
of
why,
course, we really have to look into our evaluation pattern.
Yes.
And also, I am not a member of CPSP because I have done my master's in anesthesia, and that's how I'm not into the CPSP examiner examination.
Yes. But ma'am, I'm just giving you
I cannot make comments on this.
Yes, but actually, you know, I have seen it, I have faced it. That's why I'm telling you that when I appeared in Irish fellowship exam, it was very easy for me because of the same pattern which we had back in Pakistan. Okay, at that time. But when now the people who are appearing in Irish fellowship exam, they suffer because now the pattern is changed and they are not in any practice of writing. So they suffer in that part, because now the PLAB exemption for Pakistani doctors is already finished. So they don't have anything which is giving them exemption, and if they want to do it, either they have to do PLAB or they have to do FCAI. So FCAI actually before was very easy for us because it's more clinical, and it's just like Pakistani exam with a little bit of makeup and beautification in that's more organized. So now the people who are appearing in it, they are not in habit of doing SAQs, so they have to struggle a little bit. So that's a point of view. You are absolutely right, but somehow this maybe they reconsider it, or they add something in coming days.
Actually, it's not very difficult. There are now very good softwares and plugins available where we can also construct short essays and long essays too.
Yes.
You know, but then our faculties have to be educated to do that, because I did my online and distance code certification in online and distance education, and there we were taught all this, how to make short essays and even 10 sentence long essays using some plugins. So people are not very computer friendly. That's one very important drawback here.
Yes. Anyways, ma'am, I'm again thankful to you, and I will be very happy if you give me some help out of the residents which you have, or anyone who is listening. Just contact me if you can give me some help from the residents. It will be good for them, and it will be good for me that I will be able to organize it even in a better way. Anyways, thanks a lot, everyone. And we will.
One more thing I would just want to comment here is,
Yes,
here we do not practice spinal anesthesia in lateral position, which is, I think, very important. One should learn how to give anesthesia in lateral position.
Yes, it is. It is not only for ma'am for spinal. For the people who manage to have a dura puncture and now they want to approach it, it is recommended to do it in lateral position. And because our people, they are not at all in habit or practice, they suffer. So that's a very good message which you have given. They should be doing it in like I will give you a comment that when I started to have anesthesia practice, I saw people when I'm failed, there is someone coming and trying from the lateral position. I thought this is something very nice, and I started lateral, and you will be surprised that even up till now 90% or 95% times I only exclusively give paramedian, because then I learned that paramedian is having less chances of PDPH. It's easy in, even if the patient position is not perfect, it's good in old age patient to have paramedian. It's documented to have less chances of backache, because in paramedian you are bypassing the ligaments. So ligaments are source of more theoretically temporary this backache. When you are bypassing, it's just like an intramuscular injection. The only thing which the people face is some paresthesia. When you are approaching from the lateral side, you can have some paresthesia because of and you can have some bleeding if you are happening to encounter some vessel. So that's the only thing which is documented practically. It's a wonderful technique. So this message I will add to the message given by you, that we should be targeting practicing in our during residency to do spinal or epidural in lateral position, and also in paramedian. Okay, ma'am, thanks a lot. I have to leave, and inshallah we will start a new unit. Thanks a lot for your presence. Assalamu alaikum.
Allah Hafiz. Assalamu alaikum.